chapter was
Yeah.
the PHO chapter has been very active for a long time and won the best chapter award.
Yeah.
But we've now come together within PHO chapter as Indian Pediatric Hematology Oncology Group with a bigger focus on collaborative research. And, that's been a very good development of the last, few years. You've been very supportive of the PHO chapter.
Yeah. So basically what we have seen that whatever research till now has been done is in the other countries, not Asians.
That's right.
Medicines which are effective there may not be effective in our population.
Yes.
We need our own research to take it further. And that's the reason you might have seen that I have started with a concept of called Protean Clinic with NSDL, where we are now doctor to doctor sort of consultation, where we give support for the super specialist as well as diagnostic support.
Yes.
So that is on
wonderful concept, sir. Wonderful.
Yeah. So that is on the way. Maybe by next couple of months it should start.
Wonderful.
That because you are there in various urban part, but taluka places and rural part they are not available.
Yes.
So it is online consult where a child can be managed in their own nursing home by a pediatrician, and where they need to refer, you can always guide them. So that is how the concept
will work.
Yeah.
No, it's a wonderful concept, sir.
And we'll get our Indian data also through that.
Dr. Ramandeep, sir, who's on the platform, he is very, very active in collaborating.
Yeah, I heard a lot about him, but I'm seeing him for the first time.
And he's,
Yeah.
I think amongst our pediatric hem-onc community, he's one of the most actively published researchers.
Yeah.
He's always pushing us also to do.
Yeah, I've heard a lot. In fact, in Mumbai, basically, I'm based in Mumbai, so I know the people around, like Nitin Shah, Mamta Mangali, Bharat Agarwal, and others. No? But ultimately, when I took over as a president in IAP, I got to know many names.
Yes.
Personally, I have not met anybody, but I have got to know the names. Unfortunately, during my time, there was COVID, so I could not travel much. But now, of course, we are in touch. At least,
sir, IAP was the most active in that time. With, I think, more meetings in that time than ever before. So it was, it forced us to innovate, and under your leadership, lots was achieved in that time.
Yeah. Almost every aspect of academics was touched upon. Anupam is there on this platform or just his photo?
I don't know, sir.
He must have joined.
This whole Gapio thing is very much his baby.
He's the president of Gapio at present. Yeah, correct. He's there, I suppose, till this year end.
Yeah.
You all are made the co-host, so wherever you see or want to admit anybody, you can always admit them on the main platform. Huh? Yeah.
So Dr. Parekh, as I understand, I would just take a couple of minutes and give an introduction and then invite you and introduce you to then subsequently introduce the speakers.
Correct. Right. So initially you will give some importance about the session and invite and talk about the speakers and others. And then I will invite the first speaker, that is Dr. Amita Mahajan. Yeah.
Yeah.
So
and,
please.
I was wondering, do we have any sense of the number and the audience? Is it general physicians?
Yeah, the audience on this platform will not be able to see. Mainly, we have got a DIP link, so it is we will not be able to see them. But usually, it is always more than 500. It has touched upon up to 2,000 at times, depending on the topic and the interest of the people in the topic. But definitely, it crosses 500 almost all the time.
And most of them would be pediatricians?
Yeah, pediatricians.
So both the...
So this is Gapio IAP series, no? So mainly pediatricians. But many others also join. And this Gapio, we are not going to do only pediatrics. We are going to also do surgery, gastroenterology. So now our next series on gastroenterology and trauma is ready. So this is the last session for this particular series. And then maybe we'll start with the either gastroenterology or trauma. So head injury and all those things, and gastroenterology, all the common topics like hepatitis, GERD, probiotics, all those things. So like that, we are going to touch upon, and it may not restrict ourselves to pediatrics, because GAPIO is a global physician of Indian origin. So it consists of almost every specialist. No? So there is no problem. But this particular series is GAPIO IAP series. So their IAP and GAPIO is joined together. So we are trying to get those topics which are of interest to pediatrics. But I suppose concept remains the same for everybody. Because in case of leukemia, for example, I don't think there will be a big change because age groups are always defined, no? Except for your chronic leukemias. Yeah, Nita is joining.
So we were a minute, Raman. I'll just check whether my slides so I can share easily or not.
Sure.
Hi, you can. Hi, Dr. Nita. How are you?
Hi, Dr. Bakul.
Yeah. Hi.
Hello, Amita ma'am. Hi, Dr. ma'am.
Hi, Nita. Hi.
Hi, Nita. Good evening.
Are my slides visible?
Yeah, absolutely.
Okay.
I think it's 7 o'clock.
It's 7 o'clock. I think we should start, Dr. Ramandeep. Yeah.
Okay. Let me just share my screen. I hope you can hear my, you can see my screen.
Yes.
You can see the slideshow now?
Correct. Yeah.
Okay, good evening, everyone. Welcome to this continuing series of the joint collaboration between the Global Association of Physicians of Indian Origin and the Indian Academy of Pediatrics. Through this platform, the pediatric community is reaching out to a lot of people, and today we have a very interesting talk and two stellar speakers with a lot of experience between them talking on management of cancer in children. There has been a huge change in the management as well as the outcomes of children with cancer, and I'm sure you will learn more in the subsequent hour. Perhaps it is important to showcase this by this simple graph or a set of graphs from the World Cancer Report, which show a very impressive decline in childhood cancer mortality and a very impressive improvement in the childhood cancer survival, all kinds of childhood cancer. And this is a success story for us in the field of childhood cancer. However, it is also at the same time worth acknowledging that the success story is not everywhere. The 80% of children with cancer who live in low and middle income countries do not enjoy the same outcomes as those in high income countries. And so the challenge for us is to bridge this survival gap. Now, there are many reasons for it, and obviously it is beyond the scope of just this talk as to how to do that. But one area which is very important is this whole concept of cooperative group, collaborative research. This is something which, as pediatricians, we are sensitized to and we are aware of. And in the field of pediatric oncology, this has been very well described. Perhaps the leaders among this are the groups from North America, which is the Children's Oncology Group, several groups from Europe, and as well as one from Asia, which is the Japanese group. Now, I'm very pleased to say, in the last few years, we've made progress and we've got the Indian Pediatric Hem-Onc Group. This group focuses only on using collaborative childhood cancer research as a tool to achieve its mission, which is improve the outcomes of children with cancer and benign hematological disorders. Over the last 7 years, nearly 12,500 children with cancer and blood disorders have been enrolled in 24 clinical trials in 122 institutions across the country. And you can see that over here. There is a long way to go, but this is an example of how collaborative research can start in the Indian context, and hopefully in the coming years at a different forum, we can share with you how this has led to improvement in outcomes. I'll end with this over here. I would now like to invite the chairperson of this session, Dr. Parekh. Dr. Parekh actually needs no introduction, but for those of you who don't know him, he is the president of the International Pediatric Association Congress 2023, the Honorary Secretary General of South Indian Pediatric Association, and the global academic convener of the Global Association of Physicians of Indian Origin. He has been the past national president of IAP very recently, and also the past national honorary secretary general at Central IAP. He has many publications and many awards to his name. Dr. Parekh, welcome. Kindly introduce the speakers. Thank you.
Thank you, Dr. Ramandeep, for your kind words and the introduction about the session. Let me tell you that pediatric cancer, I being a pediatrician, I'll talk on that. The pediatric cancer nowadays is 70% of the time treatable if diagnosed in time and treated in time. But we are missing on the early diagnosis at times. And to sensitize about this, we have joined hands with GAPIO and IAP to go ahead with this GAPIO IAP academic series. And in that series today, we are going to have talks on management of leukemia and management of lymphoma. And for the first talk, I invite Dr. Amita Mahajan, who is going to talk on management of leukemia. Let me introduce her as she has been trained in AIIMS Delhi, and then she had gone to UK prior to joining Indraprastha Apollo Hospital, New Delhi, to establish the pediatric Hem-Onc service with the ethos of providing the best possible treatment and outcome to each child patient at an affordable cost. She also has done outreach services for pediatric oncology and thalassemia to a number of centers in North India in public and trust sectors. She is actively involved in collaborative research in pediatric oncology in India and is director of India Pediatric Hematology and Oncology Group. She is General Secretary, Teen and Young Adult Oncology Organization, medical advisor of Can Kids, Leukemia Crusaders, and Thalassemics India, and project lead of Health Systems Strengthening Can Kids. So, court ball is yours. And Dr. Amita Mahajan, please enrich us with the knowledge on management of leukemia. Thank you.
Namaskar, everyone, and very good evening to all of you, wherever you are. Thank you, Dr. Parekh and Raman, for setting the ball rolling. And I just begin by sharing my screen. My slides are visible, I hope.
Yes.
I'd like to begin by thanking the IAP GAPIO organizers for giving me this opportunity to share with you one of the most compelling stories of modern medicine. I bring you greetings from Indraprastha Apollo Hospital, which is one of the flagship hospitals of Apollo chain. And today I'm going to talk to you about, not just because leukemia is one of the most, biggest success stories of cancer treatment, because it's not just a story of victory of science over catastrophic disease. It is a story of success of sustained human effort, persistence, perseverance, and collaboration. And it truly represents the audacity of hope, The audacity of a small group of researchers, investigators, scientists, and needless to say, parents and patients who just refuse to take no for an answer. The successful treatment of childhood leukemia has provided us with a compelling paradigm for understanding of cancer biology. The use of multi-agent chemotherapy really inspired from the success of anti-tubercular treatment. The importance of response evaluation in guiding treatment, the role of genomics in cancer leading on to the use of targeted therapy, and finally today, immunotherapy is, a childhood cancer is successfully using immunotherapy to cure cancers which were previously considered to be refractory. Much of what we do in oncology today, both in pediatrics and in adults, has really come from our understanding of successful treatment of childhood leukemia. Over the next few minutes, I'll very briefly share with you the burden of disease, the success story of ALL, our challenges and triumphs with AML, and really, again, a very impressive success story of acute promyelocytic leukemia and chronic myeloid leukemia, representing human innovation. So what is the burden? Every 3 minutes, a child is diagnosed somewhere in the world with cancer. If we add this up, it leads to 250,000 children and adolescents every year. India accounts for 20% of this burden, which is in excess of 75,000. Over 1/3 of this burden is actually leukemia, and most of it is acute lymphoblastic leukemia, as you can see in the right pie chart. It's about 80 to 85% ALL, and AML and the other rarer forms constitute the rest. So I'm going to be briefly talking about acute lymphoblastic leukemia because this is the commonest pediatric malignancy that children get and that we treat in our hospitals. The peak age of presentation is really very young, 2 to 5 years. And where the success is, before we started, Dr. Parekh was telling about somebody from his own family who got cured in 1979. But since that time, it has transformed from really a very seriously fatal disease to a disease with a cure rate in excess of 90%. So this slide just shows, and I really don't know of any other graph that is more impressive than this in modern medicine. So you can see how in successive eras of children's oncology group trials, the outcomes for ALL improved from really less than 10% to currently over 90%. So how did it all start? Again, like I said, it is because of the audacity of a few investigators. And the two first investigators were Sidney Farber from the Dana-Farber Cancer Institute and our own Y. Subba Rao, who was an alumnus of Madras Medical College. Unfortunately, when we look at literature, there we don't find so much, but the two first drugs that could achieve remission in a child with ALL were 6-MP and methotrexate, and Dr. Subba Rao actually synthesized methotrexate as a biochemist in the US because he was looking for a cure for tropical sprue. And because two of his brothers had succumbed to this condition. So this was the first time that remissions, even though temporary, were achieved and was a major breakthrough. And for the first time, cure for ALL became a goal. So these are those two people. Dr. Subba Rao, we have finally given him the respect that he deserves and the recognition in the form of a stamp. And Dr. Sidney Farber, I think most people would have heard of and perhaps may even recognize. So from there to those transient remissions, how did we get today to where we are with a cure rate of more than 90%? In the last 3 to 4 decades, very few new leukemia-specific drugs have been actually found. But we have learned to optimize the use of what we've had for a long time by applying pharmacokinetic and pharmacodynamic principles, by better understanding of biology and optimal risk stratification, by learning how to do response assessment and how to use it to titrate treatment. But very importantly for our country, how to give better supportive care. Many of you who trained in India would remember that so many of our patients when we were training just died of infection. And today that is a rarity. We are now beginning to learn how to use precision medicine to improve outcome. But each of this have come from collaborative research that Dr. Raman already highlighted. This slide just shows that how in successive eras, small changes yielded good, great outcomes, and we could transform this universally fatal disease to such high cure rates. Again, each of these innovations, as they were introduced, outcomes kept on improving. But I just want to highlight that sometimes to improve what we are, our patients or outcomes for our patients, whether it's oncology, it's just good research. On the left, you see prednisolone and dexamethasone, both steroids available to us for a long time. But through multinational collaborative research, we could found that by just changing one steroid to the other, we can improve outcomes by 5 to 10% at no extra cost. And this is phenomenal. This just tells the power of collaborative research. On the right, you see what is the difference between these arms. All children get maintenance therapy, and between 2 consecutive trials, there was actually no new innovation, but the focus was on just close titration, tighter control of maintenance therapy that all our patients get. And you can see that just by doing that, just by doing what we were already doing better, we could actually improve outcomes at no extra cost by 10 to 15%. That's the power of collaborative research and science. So what does the current treatment of ALL comprise of? A 4-week period of remission induction, followed by intensification or consolidation with further chemotherapy, delayed intensification, and just addition of this delayed intensification gave us an incremental advantage of close to 30%, followed by a prolonged maintenance phase. You will notice that cranial RT, which used to be the mainstay of our treatment few decades ago, has now actually disappeared from our treatments algorithm, and very few patients would be offered that today. I already talked about optimal risk stratification. So we are risk stratifying patients better, both based on their criteria at diagnosis and response evaluation. And apart from the clinical criteria that have been always available to us, increasingly genomics is coming to our rescue. So as you can see, ALL is not the same disease in all patients. And to be honest, every child with ALL may be different, and we are beginning to individualize or at least stratify patients based on this risk stratification. This has also, this kind of genomic analysis also helped us to improve outcomes for one of the most difficult diseases, which was Philadelphia chromosome positive ALL. And as you can see, till we introduced tyrosine kinase inhibitors, which are now available generically at very nominal cost in India, the outcome was grave. And just with introduction of that oral tablet on background of whatever treatment, there was a phenomenal incremental advantage in outcomes. I'm not able to move my slide. Yeah, we can. I talked already about response assessment. So how do we assess response? We look at minimal residual disease. And how do we, it's literally like looking for a needle in a haystack. And even in India, at many good labs and hospitals, we are able to offer that. And as you can see in this slide, titrating treatment based on MRD can help us identify patients who are at high risk of treatment failure or relapse, and help us to optimize treatment for them. But equally, it can identify patients in whom we can begin to de-escalate treatment. And this prognostic indicator currently trumps all other prognostic indicators. In the past, management of relapsed refractory disease virtually meant bone marrow transplant, and still continues to be bone marrow transplant for a significant number of patients. The outcomes of transplants have also really been improved so significantly, even in India over the last 10 to 20 years, but also innovations have led us to new drugs that can even help us take these patients to transplant so that their outcomes are better. An example, a case in point, is a drug blinatumomab, which is a specific antibody that acts on ALL cells. Many of you may have read in the papers about the CAR T cells, and this is just a very innovative approach which uses the patient's own immune system, modifies their own cells immunologically, and gives it back to the patient so they can effectively fight the cancer. And really this is something that has been transformational. It's very expensive abroad, but I'm pleased to report that a couple of patients have already received it at Tata Memorial very recently, and a lot of work is happening in this field in India, and hopefully in the years to come we will be able to offer it to many more of our patients. This is one of the first patients that was cured 10 years ago using CAR T cells, and this is from the New York Times, and she continues to be a long-term survivor today. This is again one of the first papers, and subsequently many more have come through, that patients who were labeled as refractory or multiply relapsed, we could not only get them into remission, but take them to transplant and sometimes cure them even without transplant. Dr. Raman already mentioned that we've come together, and most of this progress has come through collaborative research. So we, under the banner of INPOC, also have got this multi-centric study in progress now for the last 5 to 7 years. And I'm pleased to report that in most centers in India, where optimal supportive care and diagnostics are available, we can match the results at the best centers in the world. I'll talk briefly about acute myeloid leukemia, which really for many reasons has been much more challenging to conquer. This is a graph that shows improvements achieved in successive eras in the BFM trials. Sorry, the ALL is a misprint for AML. And yes, these are impressive, and recently these are much better, but they are still inferior to what we have managed to achieve for acute lymphoblastic leukemia. Till the 1980s, almost all children suffering from AML died, but today, up to 75% of children can survive. But the survival gap for AML is much bigger for ALL, because these outcomes are only feasible in well-structured setting where comprehensive diagnostics, intensive therapy, and effective supportive care can be delivered. So this survival gap continues to bother us, and something that we are working very actively towards narrowing. The treatment has really been, again, the mainstay of treatment is 2 drugs that have been available to us for more than 5 decades. It's the rest that has got improved. So we are able to risk stratify these patients better. We are able to have much better supportive care. The transplant, which a significant proportion of AML patients do need, has also, the outcomes have improved significantly. This again shows us what a diverse disease AML is, and the better we understand the disease, only then we will have answer to improve the outcomes. Minimal residual disease, equally important in acute myeloid leukemia, and this graph just shows that patients who have no minimal residual disease, their outcomes are much better than those who have minimal residual disease, who will really need much more aggressive treatment if we are going to be able to cure them. As a pediatric oncologist, I feel that pediatric oncologists led the world in terms of ALL treatment, and really a lot of adult protocols are currently based on pediatric inspired strategies. But in terms of AML, because the treatment was so intensive, many elderly adults could not handle. So a lot of research has been done in the adult world, and I think as pediatric oncologists, we have a lot to learn from the recent successes in adult AML treatment of innovative approaches. Some of these approaches are use of monoclonal antibodies, use of FLT3 inhibitors or targeted therapy, use of drugs like venetoclax and azacitidine, and each of these are available to us, but our experience in the pediatric world is just beginning to accumulate for these specific modalities. I just want to talk very briefly about acute promyelocytic leukemia, because the innovation in this field have been very dramatic. Initial success with acute promyelocytic leukemia, and many of may remember that these patients would just bleed to death soon after admission. With anthracycline, initial successes were reported. but their management and outcomes have been revolutionized by the use of non-chemotherapy agents such as the oral transretinoic acid and arsenic trioxide in late 1980s and late 1990s. Multicentric studies over the past 3 decades, initially from China and India, have demonstrated the efficacy of this non-chemotherapy regimen. And very briefly, I just want to share this very recent publication of using no chemotherapy in most of the patients with APML and very limited chemotherapy in some high-risk patients. And the reported results of this recently concluded trial showed an event-free survival of 98% and overall survival of 99% with virtually very little or no chemotherapy and no deaths due to bleeding or thrombosis. So this is phenomenal. And again, arsenic was something that has come from traditional Chinese medicine, traditional Ayurvedic medicine, and just through research, through meticulous research, we can now offer it to all our patients, and leave them with no late sequelae and such wonderful cure rates. Finally, just 1 or 2 minutes about chronic myeloid leukemia. It is a rare condition, but again, this is a condition where innovation transformed outcome. This was a condition where the only curative treatment was bone marrow transplant. And then by understanding biology, genomics, we found tyrosine kinase inhibitors. And these literally transformed. So this is a drug which is an oral pill, which has virtually very little or no side effects, and most patients will be cured. And this drug completely dramatically changed the landscape of CML. 1 month's treatment in India would now cost maybe 1,000-1,200 rupees. And the life expectancy in adult patients is now almost identical to their age-matched healthy population just by using this medicine. Children do have a much more aggressive course, but we are learning how to optimize it. And treatment with TKIs has again transformed their outcome, and transplant, which used to be the only curative treatment, is now a third-line treatment offered to a very small study, a small group of patients. Prospective studies of TKIs, we are now looking at how and when can we stop this medicine. But all this, as we were learning to improve outcomes, came at a price. The cranial radiation that we used to give, some children went on to develop brain tumors, endocrine and neurocognitive sequelae, cardiotoxicity because of anthracyclines. And now, not only is our focus on improving outcomes, but also limiting the price of cure. So each time a new strategy or any trial is designed, it looks at limiting the price of cure. So our patients are not just survivors, but they lead completely healthy lives as they go on. It's also important for us to remember that leukemia strikes children at their most beautiful age, an age that is meant to go to school and play. So it's important that we create a very patient-friendly environment in our organizations, in our institutions, so that we don't rob them of all the childhood happiness. I encourage my patients to come to the hospital for their visit and chemotherapy dressed in their Sunday best, because they're going to grow out of it anyway. So might as well wear them to the hospital when they come, and this really cheers them. We learn that we must celebrate the small happinesses, their birthdays, getting a small award for whatever they have done, and so that we learn to celebrate their lives with them. Then they have something to look forward to, and each time a celebration reaches out to so many other patients and other survivors that they could also be holding a medal or award someday and lead normal lives. But to be able to do this takes collaboration. It takes a village to raise a child. It also takes many people to give optimal treatment for childhood cancer. In our organizations, we don't have all these people, so we use multitasking. We do multiple roles, but we are good at it. In India, as pediatricians, we've always multitasked as the nutritionist, as the psychologist, not just for the patient, but for the whole family. So each of us do many of these roles. And I'm sure, I am very confident that our training in India helps us to do this multitasking. And now we, like I said, collaborative research is the mainstay of improvement. And Raman already told you that we've come together as INPOC for collaborative research, which is looking not at just research, but improving access to care. access to best possible treatment and care should not be a privilege. He highlighted the survival gap. But I think for children, if IAP and GAPU and INPOC come together, we can minimize this gap. Where a child is born, which family, which district should not impact his or her chance of cure. And I think we are together on that page. I'd just like to end by using Dr. Frerich's words. He's known as the father of modern chemotherapy. And he was working till the age of 93 when we lost him. He was at MD Anderson when he passed away last year due to COVID. And he was working even till that time. Childhood leukemia will always be around, but every day we cure more and more children who will live normal lives and go on to do great things. Thank you so much for your attention, wherever you are.
Thank you, Dr. Amita, for an excellent talk. I suppose it was the picture which you showed was a holistic management of a child cancer. And I agree with you that we should be able to give quality care to every child everywhere. It should be equitable. So I really thank you for excellent overview of management of acute leukemia. And we'll request all the delegates and those who are on the screen and off the screen, you can put your questions in chat box, which will take up after the second talk. The second talk is on management of lymphoma. And for that, we have our colleague, Dr. Neeta Radhakrishnan. She is an associate professor and head of Department of Pediatric Hemato-Oncology at Postgraduate Institute of Child Health, Noida. Her special interests are childhood cancer, coagulation disorders, and primary immune deficiencies. After completing her MD in pediatrics, Dr. Neeta received DNP fellowships in pediatric hemonc from Sir Gangaram Hospital, New Delhi, and fellowship in hemostasis and thrombosis from University of Milan. Dr. Neeta serves as the Honorary Secretary of Pediatric Hemonc Chapter of Indian Academy of Pediatrics and is the section editor for Pediatric Hemonc Journal and is reviewer for national and international journals. She has published more than 50 papers in peer-reviewed journals. So who best other than Dr. Neeta? So I invite Dr. Neeta Radhakrishnan to give her talk on management of lymphoma. Over to you.
Thank you very much, sir. I would like to thank the Global Association of Physicians of Indian Origin and IAP for this opportunity. And like Dr. Amita just spoke, it takes a village to raise a child. Similar to that, it takes a village to treat a child with any malignancy for that matter. So all the effort that we are seeing is the result of generations of people before us who have worked for the same cause. And I think this is just proof of concept that when we collaborate, a lot of things happen. And this is just an impetus for us to collaborate more. So in the next few minutes, I'll be discussing management of lymphomas in children and how, what is the success story there as well. So similar to the graph that was shown earlier, in lymphomas as well, there has been an improvement in the survival over the years. So to the extent that when Hodgkin lymphoma was described initially by Dr. Hodgkin, the 7 children in whom he described it was all those 7 children succumbed to the illness. Slowly, there was work on what causes lymphomas and what is the treatment of lymphomas. And slowly, with collaborative efforts, we have reached where we have now. The main 2 things that have happened in lymphoma treatment is that we have learned to do risk-adapted treatment. So not every child with the same disease or with the same pathological diagnosis does not receive the same treatment. The second is similar to what we saw in ALL, we have learned how to treat based on the response that is there. So response-based treatment stratification and risk adaptation is something we have learned over the years. And that has been the reason for the success. It's not really new drugs that have played the role. It's just the way we use the same drugs that has actually improved survival. So lymphomas overall survive around are a reason for around 15% of childhood malignancies. That the 3rd most common childhood cancers after leukemias and malignant brain tumors. And if you look at children, this is the data. But if you look at adolescents, actually lymphomas become way more common. So around 20% of adolescent malignancies are actually lymphoma. So that is the, if you look at data in adolescent and young adults, the AYA population, this is the single largest malignancy again in 15 to 19 in childhood. So more than 98% of these children are going to remain event free, as in what is the chance as to what we can reach in terms of cure. What we need is to improve the long-term morbidity of these patients. So if you look at epidemiologically, when you compare India versus developed country, more younger patients presenting with the disease, we have more patients presenting with advanced disease, and these symptoms which symptoms like fever, symptoms like weight loss are
Neeta,
in
your
our patient population.
sorry,
compared
Dr.
to the
Neeta.
types haven't changed over the years. There are beautiful reviews on different.
Dr. Neeta.
Am I audible now?
Yeah, no, your network, I think, is poor. So you can stop your video and.
Yeah, I'm. Yes, sir. Is it okay now? Can you hear me?
Little better. Yeah.
Okay. So the internet is a bit patchy. I'm trying to connect through a geo network. So, this is again the staging, which hasn't really changed much at all. We have recognized EBV associated HL as a different entity, which is more common in children economically backward groups and with patients who are boys and younger than 10 years of age. In Indian data also is there that majority of population in India might be EBV associated. Prognostically, we have realized that if you have a younger child with a favorable biology and early stage disease, these children are going to do well. But the sad fact is majority of our patients actually come with bulky disease with B symptoms and a high ESR. So these are things which as a country we are facing, as developing countries or low and middle income countries, we are facing commonly. So the usual regimens which were used for treatment are ABVD or OIPA-COBDAC. These are agents which have been used. Over the years, we have learned that PET-CT-based response assessment is important. And pediatric Hodgkin lymphoma, there is a lot of multicentric trial that has done. And over the years, we are moving away from alkylating agents. We are reducing the dose of anthracyclines that we are giving to our patients. We are also trying to reduce the dose of radiotherapy or even omit the radiotherapy that we are giving to these patients. So all this is intended towards reducing the long-term morbidity of these patients. So when you safely omit radiotherapy or even the dose, the long-term cardiac morbidities, many patients present with cervical and mediastinal disease. So radiation to these fields can have long-term thyroid as well as mediastinal involvement, cardiac involvement can be seen. Even lung fibrosis can be seen in these patients. Similarly, in intermediate or high risk, again, risk stratification is slightly different between the different cooperative groups, but overall treatment over the years have reduced the radiation exposure as well as cyclophosphamide exposure in these patients. Madam just spoke about, when Dr. Raman spoke about INPOG, that is the Indian Pediatric Oncology Group. So Hodgkin lymphoma again has been one of the success stories of INPOG, where this data was recently published a couple of years back, where 418 patients across the country were analyzed, and 40% of those patients had bulky disease. And even with a limited treatment with ABVD, which is a standard treatment which can be offered, even in very small centers, this can be offered very easily. And radiotherapy in select groups of patients, these children are more than 5-year EFS and OS was more than 90% in these groups of patients. So that is the response of Hodgkin lymphoma that we get. Even when Hodgkin lymphoma relapses, again around 50% patients can be salvaged. So even Western data says that we can have progression-free survival of around 56%. What matters in patients who relapse is that when they're relapsing, what is their condition at the time of relapse? If they have relapsed very early, then probably they have chemo resistance. Extranodal disease, if it's there at the time of relapse, and what is the first line chemotherapy? If they have received something like ABVD and when they relapse, they are more salvageable than when they receive something more intensive. What happens to Hodgkin lymphoma in long term? We said they are going to survive. More than 95% of these children are going to survive. But if you look at very long-term data, 30-year, 40-year data, we see that the survival actually comes down over the years. After that, it's not disease-related morbidity. It's actually morbidity because of either a second malignant neoplasm or because of lung or cardiac involvement. So these are things which we as groups, as cooperative groups, people are trying to reduce the exposure to anthracyclines, exposure to cyclophosphamide, exposure to radiation, so that this long-term morbidity can be taken care of in Hodgkin lymphoma. In Hodgkin as well, there are a lot of targets which are there, therapeutic targets. So a lot of researchers used to wonder why the malignant cell it's inside a lot of, in between a lot of inflammatory cells. It is still not attacked by the inflammatory cell because the malignant cell, which is the Reed-Sternberg cell, actually has a way to evade immune surveillance. So based on these studies, people have identified targets which can be which can be targeted through treatment. So brentuximab is one agent, bortezomib is another agent. These have been studied and there are results in pediatric population as well. What is most important, like all childhood malignancies, is that early diagnosis is very, very crucial. 40% bulky disease we heard of from the IMPOC trial data. Many of our patients present to us after stage 2B. That is because when they were at this earlier stage, they were not being picked up. They were thought to have either tuberculosis or some other infection. Many a times an FNAC was done and just left at that. So these are the reasons why disease just keeps progressing. We have patients coming to us after 1 year of onset of lymphadenopathy. It was just a disease is so indolent that it did not harm the child. And unlike in NHL, which is very aggressive, a child will not survive for a year. Hodgkin children can survive for many, many months before a diagnosis is made. But this is at the cost of increasing the morbidity, because the stage of the disease increases, treatment increases, overall morbidity increases. So that is why we need to diagnose these children at the earliest. So whenever we have lymph nodes which are going on for more than 2 to 4 weeks, constitutional symptoms are there. If there is asymptomatic lymph node also which is not coming down within 6 weeks, always biopsy. A supraclavicular lymph node is always abnormal and it has to be biopsied. So biopsy, and FNAC is not equivalent to biopsy. Many a times you miss a lymph node focus, the disease focus inside the lymph node, and that is why all these excision biopsy has to be thought of. Now coming to non-Hodgkin lymphoma. Again, equal percentage as that of Hodgkin lymphoma. Unlike in adult non-Hodgkin lymphoma, there is a huge classification of indolent non-Hodgkin lymphomas which are seen. Whereas in pediatric non-Hodgkin lymphomas, a very, very aggressive disease. And these are the top three are the most important categories. You have Burkitt lymphoma and DLBCL, which are both of them are mature BNHLs. Then you have lymphoblastic lymphomas and anaplastic large cell lymphomas. What is important is that they are aggressive, they spread very quickly, and they are unpredictable. They have a lot of CNS morbidity, unlike in Hodgkin lymphoma. They double almost every 24 hours, so that is important as well. And so early diagnosis and treatment is important. Many patients with non-Hodgkin lymphoma have underlying immune deficiency. So this is also something like HIV, something we look into for all patients, especially. Now, what is the difference in presentation between Hodgkin and non-Hodgkin? Oncological emergencies are way more common in non-Hodgkin lymphoma. It could be based on the superior mediastinal syndrome if it is a T lymphoblastic lymphoma, which is an NHL. It could be abdominal distension if it is a patient who is present with a Burkitt disease, DLBCL, all these, spinal cord compression, pericardial tamponade. These are all common presentations in non-Hodgkin lymphomas. So this is a patient who had an intramedullary lymphoma presented with paraplegia. These are children, again, difficult to differentiate Hodgkin and not Hodgkin's based on this itself, because we see a lot of presentation which is delayed, especially because of diagnosis, because of coexistent tuberculosis or wrong diagnosis of tuberculosis. Tumor lysis is something which we are very worried about in patients who present with non-Hodgkin lymphoma. So there is a classification for it and a very, very aggressive management with allopurinol as well as raspuricase, both are which are easily available in our country currently. And among the non-Hodgkin, Burkitt subtype presents with abdominal disease, ascites, intussusception. So again, pediatric patients who have intussusception and are getting a surgical excision of that, it is mandatory to send the tissue for biopsy. And if it is reduced through other means, again, look at a CBC and a KFT very closely to rule out any involvement in the thing. So if there is a slightest of suspicion on KFT, a high uric acid, the child should be evaluated further. So these are differential, this is how it is diagnosed. What is the difference in treatment strategy? There are three different types of main types of non-Hodgkin lymphoma. So among that, the lymphoblastic lymphoma, they are treated similar to, they are actually immature cells, similar to that of ALL. So they are treated like ALL. They'll have a long maintenance like Madam just described. Whereas if you have patients with Burkitt or Burkitt-like disease, they are treated with short intensive duration of treatment, small cycles, very aggressive cycles, but then the treatment duration may be around 6 to 7 months. And anaplastic large cell also is treated as a separate group, again with pulsed chemotherapy and one agent which is very effective in anaplastic large cell lymphoma, both upfront and in relapse setting, is vinblastine. So these are ways of different protocols which treat lymphoblastic lymphoma. This is how a Burkitt leukemia or a Burkitt cell looks like, with a lot of vacuolation in the cytoplasm. And over the years, understanding from the time endemic Burkitt was described in African, sub-Saharan Africa, from there to sporadic Burkitt to stratification of the disease, staging, different cooperative groups have been involved in this malignancy as well. And we know that as the stratum increases, the overall response reduces. So the challenge is to diagnose them early. So the group A treatment, the earlier is group treatment, the children who are either presenting very early or abdominal intussusception, completely resected patients, these children can be treated with just 2 cycles of small chemotherapy, and the treatment, their response is again wonderful. Whereas children who present in the intermediate group, again, if you treat them, the treatment is intensive compared to group A, but still, once you finish the treatment, if the child responds to the treatment, then overall survival after that, the event-free survival is extremely good, again, upwards of 90%. And patients who present with high-risk disease, which have involvement in the bone marrow and the CNS, again, these are children who require very intensive treatment. These are the ones who are coming with tumor lysis upfront. So initial few months, or at least the first month of treatment, is going to be challenging, especially with the kind of malnutrition that we encounter in our scenario. But once you survive that, there is upwards of again 80% survival in this group of patients as well. In Indian data is available for NHLs as well. So this was published recently, 191 patients from different centers with BNHL, and 65% the primary site was abdomen. Treatment protocols are not uniform in our country. We had both patients treated on LMB as well as BFM protocols. Treatment related mortality is close to 14% in Indian data. So when NHL relapses, then again, there is treatment. It is not like it is the end of the road for a patient. It is difficult compared to Hodgkin relapse. NHL relapses are difficult to salvage, but still treatment options are available for patients with the targeted treatment as well as bone marrow transplant. Options are available for relapsed refractory NHLs as well. And as in acute lymphoblastic leukemia, there is a lot of role which is coming up for CAR T cells in lymphoma as well. So these are treatments that have revolutionized malignancy treatment as such. So now cellular immunotherapy is available, and in our country as well, this has been given for patients with refractory B-cell lymphomas at Tata Memorial, Mumbai. So I think I'll conclude here. These are fulfilling times for treating pediatric cancer, because not just risk stratification wise, or not just we have better understanding of the biology, but we have a lot of supportive care options which are right now available with us. There is a plateau in survival for Hodgkin lymphoma even in our country. So now the emphasis is to reduce long-term morbidity. And in NHL, the emphasis is always on supportive care. And like I said in the beginning, early diagnosis definitely improves outcome. So I thank you for a patient listening. I'll be happy to take questions.
Yeah, thank you, Dr. Neeta. You gave so much in such a short time. जैसे हिंदी में बोलते हैं गागर में सागर. You really showed us the full picture of how you treat or manage lymphoma. And I'm sure there are going to be many questions in everybody's mind. And I'll request Dr. Ramandeep to take over and ask few questions if there are any. I don't see any questions in the chat box, but we can ask on our own, Dr. Ramandeep.
Yes, please. Thank you. Thank you so much. I think there will be questions, and I would set the ball rolling by asking the first question to Amita. Amita, you very nicely showed how it is not just the drugs and the treatment protocol, but other aspects which have to be looked after. Now, there's a general perception that a child has leukemia, the treatment is going to be long and complex. It's going to be costly. The family doesn't have means to support it. I should not even refer the patient. I should, not even offer them treatment. What do you say to such families and such doctors who are in certain areas where there is a challenge accessing care, affording care? What kind of things do you do? What does the government do? What resources are available for such patients?
Thank you, Raman, for bringing this up. And today, like Neeta said, these are very fulfilling times because there is nobody, not a single child that needs to be turned away because of lack of access to resources. The government, first of all, there are so many funds within the public sector, even for patients being treated in the private sector, because sometimes because of logistic challenges, for a poor family, still public sector may not be their first choice for so many reasons. Or distance. And there is so much support from various government schemes, the relief funds. And to parallel that, there are over 90 NGOs that are working for childhood cancer in India. And they're all over the country. We are mapped for that. So I think if there are any pediatricians who feel that, this family will be destroyed for treating with, for cancer, or, I'm actually doing an injustice to the family, because they're drained on their resources, I can say on behalf of our entire community, please refer them to a pediatric oncologist. They will make sure that they have access to these resources. We all have a full-time social worker. Part of my job as an oncologist is to make sure that their resources are not drained. And in principle, we will not allow anybody to sell their land or girvi rakhna or sell their jewelry, because there is so much help out there today. And I can say that for childhood cancer, that is not a burden. We do seek help for shared care from our partnering colleagues, because many of the things for various cancer will need to be and can be done in their local areas. And that's why a lot of emphasis of the current PHO team is to build these partnerships or shared care, which can reduce not just the financial, but a lot of logistic burden for the families. And we are sort of coming together as a community. But support wise, obviously there is no time to go into the details, but there is a lot of support out there, and we learn to use each other as well. So if I need somebody, I can send to Neeta's center, and if there is something that's not available at her center, she can send to us. And we, for us, private, public, trust, all this has blurred. We are together one community to improve, reduce the survival gap. And we are fortunate today to have so much support from from various sources.
Thank you,
Dr. Raman. So wonderful, Dr. I will like to ask one question. Though you said that there is a financial support and other support, but many times as pediatricians we hear that diagnosis is diagnosed late, and because of that various complications, the diagnostic cost is very high, the treatment part is in lakhs. So many families, they opt for not doing any treatment. And when we refer to some government hospitals, sometimes they are not given much attention, and that's why they go away. And then they leave the child to do whatever happens naturally. So this was a very encouraging message from you that yes, we can refer to anybody and they will be supported in financial matter as well as otherwise. But may I know what is the usual on an average cost for diagnosis as well as management?
So the diagnostic cost has come down, but it can, if we want to do all the proper risk stratification, all the genetic testing, it would still for an acute leukemia patient, whether it is the government or whether it is the patient, whoever are NGO paying, it can still add up to 22. So it is substantial. It can add up to 20, 30,000 or even more. But our plea to the NGOs has been the barrier because of you can access government funds once you have a concrete diagnosis. But most of our families don't even have the money. So our first plea to the major NGOs was that give us that bridging finance or take over the burden of diagnostics. Because if your benchmark is that come to us with a diagnosis, then we cannot reduce the survival gap, because many patients in our country do not even have this 30, or they may have exhausted it on other things before coming to us. So the NGOs know that the government funding will take time. Even in the public sector where treatment is free, some tests may need to be outsourced, at least for now. It's getting better and better. So we can just ask them that this is the sample, please get the test done for me, including a PET scan for Hodgkin lymphoma. So I'll just share, Dr. Neeta showed in our collaborative study, it was our stand that PET CT is a luxury. We can manage without that. But in our analysis, we could see that if we did the PET CT, then we would be able to spare many more children from radiation. So we have written to the NGOs that please consider including, yes, it comes at a cost, but look at the cost that will be spared in the long term. 20,000 now will be, it is value for this child. So we are trying to be go to the, as an advocate and push, like, again, some of the tests that we described were considered a luxury. MRD was a luxury. That why do we need MRD? We can manage without it. But we realized that, that will help us to stratify the child's treatment, maybe reduce the treatment. So one NGO just took over the charge that we will give MRD to any child in the country who needs it at no cost. We will get the sample picked up from their center. So, we have to go to them with what we need, and they will come for. The government is, just doing phenomenal work.
Thank you for the information.
I think, Amita, this is a very good point to bring in Neeta, because Neeta works in a government hospital in UP, which is a flagship hospital for offering pediatric oncology care. And not only is she providing clinical service, but she's also involved in developing policy, advocacy, meeting the stakeholders, the government. So Neeta, can you tell us, in a vast state like UP, where access to care, the number of centers, the physicians has always been a challenge, what efforts are being done within the government sector to try and ensure access to care and affordability of care? Just unmute yourself, please. Thank you.
Yeah, thank you. I'm really sorry for the signal. I just read your message that my signal was up and down. It is some issue with the service provider. I'm really sorry for that.
So later on, you were okay when you stopped your video. Yeah.
Okay, sir. So yes, working, and so in the last 5.5 years, I've been working in Noida, which is a government facility. And we have started pediatric cancer services from the scratch. So the challenges that we have faced is in terms of patient access and patient referrals is that, like you said, I find that there is a lot of difference when we treat patients in Delhi versus patients in Western UP, because a lot of people, they have this misconception that if you have a diagnosis of cancer, it is the end and there is no further way ahead. So it has started from physician awareness, ASHA worker awareness. It has started from pediatrician awareness to slowly build the trust that no, it is not the end of the road. Even patients who are so-called high risk or so-called relapsed ones, not all can be salvaged, but definitely 50% of these children also can be salvaged. So the trust builds up over the years, and it's a word of mouth which actually works rather than anything else. So we've had patients who go back A lot of patients don't even turn up to a hospital. So if you look at, I think even in the data where if you look at patients who are expected to come from the population, even in that, from all centers put together in UP, we would be probably catering to 30% of those expected patient numbers. So this is the challenge. A lot of patients do probably go out of the state for treatment, but even then, we are seeing a minuscule of the patients who are actually supposed to be diagnosed. So challenge rise in multiple areas. We've had abandonment rates again. Patient comes, gets diagnosed, offered full treatment free of cost. Also some of them abandon treatment. Why? Because one, either somebody, again, misconceptions in the family, or the second major challenge is that patients flatly refuse treatment, saying that if I am here getting my treatment done, who will take care of my family? So that's the biggest challenge. So even when there are NGOs who will provide them food, ration for the whole family, even then there are challenges of abandonment. So these are things which we are slowly working on, trying to do survivor clinics. So that's something which has helped our center, because we do a survivor clinic every last Friday of the month. And when you show them a patient who has been treated, cured, and is doing well, going to school or doing a job, that kind of builds confidence among the children who are being treated currently. So that has helped again. And from the government side, Ayushman Bharat is a service which covers pediatric cancer for the whole country, for most of the states in the country. But Ayushman Bharat, if you are in an Ayushman Bharat, if you get coverage under PMJ or Ayushman Bharat scheme, then treatment is not at all difficult. At least in most, as in 70-80% of treatment can be covered under this. But the problem is that many of these patients are not, because most of Ayushman Bharat database is based out of the last census, which came in 2011. Because many of our patients were born after that. So many of them don't have their name in the database. That's one big challenge. So we have to write and we have to get them enrolled through their parents. So that takes time again. Like other government funding, this also takes time. But once they are in the scheme, then it's easier to treat. And overall, government has been working towards improving. So now through Ayushman Bharat, there is a program going on in UP through a CSR activity of a company, that they are doing training for multiple malignancies. It's not just pediatric, it's adult as well. So mainly focused on adult, but then this is to improve diagnostics and improve treatment or standardized treatment in all centers which are covered under PMJ scheme. So that is expected to have a huge impact in terms of patients receiving treatment at a local center rather than having to come to a tertiary care facility for each chemotherapy. So these are ways in which we are working. And we recently had a childhood cancer advocacy group also, which was launched in the September of last month. And slowly we are trying to tell government that these are the things that we are facing, and probably challenges will emerge as we go.
Nita, thank you so much. We are out of time, but I really want to just take 1 minute. And Amita, if you can talk about, as pediatricians, we love the World Health Organization. Can you tell people about the recent global initiative on childhood cancer, maybe just in a minute so that we don't shoot too much of our time, and sensitize people about this? Thank you.
I just want to say that WHO has really taken the cause of childhood cancer forward with a Cure for All initiative. Of course, it has to be graded, but it is our target, and they've created task force within that platform, and many of us are part of those various task force. It looks at access to diagnostics, access to care, all the challenges that Dr. Nita was describing. And really, it is currently aligned with where the INPOG is going, where the PHO IAP is going, and where the IAP is going. So we feel that this is a very good time for the WHO initiative, because we are also thinking along those lines. There's a lot of government support for that. There's a lot of NGO support for that. And as a community, I think we are finally coming together. And I say on behalf of all of us that the next decade is really going to be transformational for pediatric oncology.
Thank you, Dr. Parekh. I think you should have the last word.
Yeah. So thank you very much, Dr. Ramandeep, for moderating this session very well. And of course, both the star speakers, Amita and Nita. Yes, really, you've given a good knowledge of what is possible and what is not possible. I think not possible is not there. What is possible, and pediatric cancer is definitely treatable. Everybody should diagnose it early and send them to the hemato-oncologists without worrying about finances and other support, because they are already there. And I'm sure with all our efforts, as you rightly said, that it requires village. So we all have to join hands together to get the better results. Thank you very much for
Thank
both the speakers for excellent talks. I must say that you were excellent. Thank you very much. And of course, I will like to thank GAPIO leaders, Dr. Anupam Sibal, Dr. Tandon, and others. And on IAP side, Dr. Ramesh Kumar, Dr. Vinit Saxena, Dr. Upendra Kinjwadekar, and all others who have taken part in this. And it's, of course, our IT team who has given this platform to us. And not last but not the least, all the delegates who are there on the platform and of the screen. Thank you very much. Keep joining us every time whenever we have a talk, and I'm sure it will be enriching your knowledge and academics. Thank you.
Thank you.
Thank you.